Hey guys, it is Shelby, and we're on chapter 5, the hardest chapter of them all for this first exam. There's a lot of information. Again, I did not make these slides. My professors did at Simpson. So this first slide, cells within our body within a fluid environment that require a balance of electrolyte and acid-base balance for homeostasis. It's a very narrow range, so we gotta keep that balance really finely checked. Electrolytes are minerals that give electrical charge in the blood, which compose of the heart, kidneys, and organs for function. Too many or too few electrolytes can lead to serious consequences. Capillaries are tiny branches that work between arteries and veins. Fluid moves in and out of the capillaries. Various pressures, forces such as osmosis and diffusion will be talking about the forces today. So in general, water weighs 2.2 pounds or 1 kilogram. Intracellular fluid is 2/3 of total body weight. Extracellular fluid is only 1/3. Extracellular fluid is found in the interstitial fluid, aka blood plasma too. So interstitial space refers to between the cells and outside of the vessels. So just remember, blood plasma is not part of blood cells. So it's still in the capillaries, but since it's outside of the cells in the outside of the red blood cells in the capillaries, it's still considered extracellular fluid. And then outside of the capillaries, in between the cells of the interstitial tissue, would be extracellular fluid. Total body weight percentage of an individual depends on the amount of body fat. So little water is absorbed in fat tissue. So the higher fat you have, the less total body water. So sorry, I was saying total body weight. TWB means total body water. So it will. So the fatter you are, the less water you'll have, and you're more prone to dehydration. With age, total body water declines, and older adults have decreased muscle mass, decreased kidney function, diminished thirst perception, and the sodium pump slows down, which all causes effect on how much water we're absorbing. Pediatric patients, so peds patients, babies, they have greater levels of total body water, and if they ever get an imbalance, it quickly needs to be corrected. Just note that the number one way we lose body fluids is through urine and breathing out in and out of our lungs. So mostly out of our lungs because we breathe off CO2 and H2O, water. So yeah, urine and lungs. Okay, here we're talking about forces. Okay, these are called Starling forces, and we're going to start off on the filtration favoring side. So the filtration favoring side is the forces that push into the interstitial compartment. So capillary hydrostatic pushes water out of the capillary into the interstitial, and the interstitial oncotic pulls water from the capillary into the tissue. And these are favoring filtration forces. Now, for favoring reabsorption, so going back into the capillary, we have plasma, or you can call it capillary oncotic, that pulls water from the interstitial fluid into the capillary, or we have interstitial hydrostatic that pushes the water from the tissues into the capillary. This is reabsorption. So note that filtration is going into the tissues, reabsorption is going into the capillaries. Oncotic is equal to osmotic, capillary is equal to plasma, interstitial is equal to tissue. We have various names for these, and it can trip you up, but if you make sure to know what each one is equivalent to, you could probably figure it out. Also, what the teachers taught us is that hydrostatic is pushing and oncotic or osmotic is pulling. Okay, this is a quick question. We're going to go ahead and skip that. Oop. Okay, so water movement between ICF and ECF. Also I want to note back here, so in nursing tests, we want to choose the best. So it can be a correct answer, but we want to choose the best correct answer. And just note that the capillary pressures are always the ones that are causing movement of water pretty much 99.7% of the time. Interstitial, yeah, you have pressure going on there. But really these guys, the capillary oncotic pressure and capillary hydrostatic pressure are the main forces that are going to depict whether we're having that fluid shift into our interstitial or capillary spaces. Okay, ICF and ECF water movement is driven by osmosis. So water follows solutes. So in a hypotonic solution, let me go ahead and draw this for you guys. So in a hypotonic solution, we have a cell, right? When we're talking about a hypotonic solution, we're not talking about inside the cell. Solution means outside of the cell. So say we have 2 dots in here. Hypotonic, we only have like 1 dot. So we have a lot of solutes in here and not a lot outside of the cell. This is called hypotonic, and we're going to have water follow the solute, so the water is going to rush inside the cell and cause this to swell. That's what a hypotonic solution would create. Now we're going to talk about a hypertonic. So hypertonic, we have a cell, and we're talking about the solution. So hyper, more on the outside. Solution always means outside of the cell. So we have a lot of solutes out here, okay? And we say we only have 1 solute in there. So since water follows solute, so the water from inside the cell is going to rush to outside of the cell because water follows solute. So this is going to cause the cell to shrink and shrivel. Okay? So that's basically osmosis. Yeah, here we go. Edema. So edema is the result of accumulation of fluid within the interstitial space. It involves hydrostatic pressure that increases from the capillaries because of obstruction and water retention. So again, drawing it for you. Okay. Should have not done that many dots. Let me just undo this. Okay, so say, I'm going to choose a crayon this time. Say we have our blood vein and we have an obstruction right here, right? And we have this blood flowing through, but since it's obstruction, it's going to build up in the vein. So we're building it up. Now, have you guys ever twisted a hose? Like you obstructed the hose? What happens is water builds up back here and the hose kind of inflates like this. And that's because we have a lot of pressure from a lot of buildup behind it. What eventually happens is it increases the permeability. So there you're going to have increased capillary hydrostatic pressure. So we're going to have the water water be pushed out into the interstitial tissue fluid. So that's what causes that's the increase in capillary hydrostatic pressure or decrease in plasma oncotic pressure. So basically, why do I always do this to myself? Oh, I can click redo. Oh, never mind. I was just adding more. Okay, so basically, with say we have our red blood, not red blood cell, our vein, and we have these proteins in here. So like I said, water follows solutes and protein. So what normally would happen is water from the interstitial fluid would go up into this for reabsorption. However, if we get rid of some of those, we don't have a lot to pull. So when we have a lot, we have a high oncotic pressure of the capillary and we're being able to pull. But now that we have only a few, we're not getting so much of a pull. So this water down here is going to kind of stay down here because these guys really can't, they don't have enough strength to be able to pull it up. So you want more proteins to be able to pull that water back in to the capillary. So now that's what's going to cause the water to hang out in the capillary. So decrease plasma oncotic pressure, increase capillary permeability. So like I said, with the hose building up, that's going to stretch the wall. And now since we're stretching it, we're going to have increased permeability. It's like if you have a hole in your jeans. You can have a little hole in your jeans, that's fine. But once you start stretching those jeans out, you're going to get a bigger hole. Same thing with the capillary. And lymph obstruction, same thing. It's basically, like I said, just with the lymph of, like, rather than the capillaries, it's the lymph, and you're going to have more lymph go into the tissues. Okay, so all of these can cause edema, heart failure, renal failure, cirrhosis of the liver, salt and water retention, and plasma volume overload, increased capillary hydrostatic pressure, can all cause edema. Someone who's malnourished could have low plasma albumins, which decreases the plasma oncotic pressure. inflamed capillaries are more permeable when you have trauma or burns. So that makes sense. Like if you burn your capillary, the wall of your capillaries, obviously that's going to cause a hole in it. And so now more stuff can flow through that hole. Um, and then also blocked lymph channels, like I said, you stick a rock in the hose, it's eventually going to pop and that fluid is going to flow out. So it's going to flow into the tissues. Yep. So decreased movement of the nutrients between capillaries and tissues could negatively impact wound healing, which can take um, healing. It can take longer for a wound to heal when you have edema. And yeah. So, yep. Moving on. It also states unavailable. When fluid becomes trapped, it's unavailable for metabolic processes and also can cause perfusion, which can result in dehydration. Unused fluid deprives body. Okay. So this is just like a kind of overview again of what could cause edema, lymph obstruction, increased hydrostatic capillary pressure, decreased oncotic pressure, increased capillary permeability, and increased tissue oncotic pressure. So increased tissue oncotic pressure would be, say you have I should have done it in red. Let me do that. Say you have your capillary in the tissue, so outside the capillary we have more of these guys, so we have more strength to pull the water and keep it this down here in the interstitial. Okay? All right, pitting edema. Note that all edema, not all edema is pitting. So you can have pitting or non-pitting. It's basically just press on the tissue and see. Sodium and chloride balance. Kidneys and hormones regulate sodium and water within the body. Sodium is regulated by renal effects of aldosterone, and water is regulated by antidiuretic hormone. Sodium is primarily an ECF cation, so sodium is normally outside of the cell. And sodium regulates osmotic forces, which is responsible for water balance. Sodium also maintains nerve impulses. If you remember back to an action potential, that all deals with, let me go to it, an action potential. So images. You guys remembered this where sodium goes in and then potassium goes out. You guys remember action potential? Keep that in mind, okay? So it maintains nerve impulses, regulation of acid-base balance, transports substances across the cellular membrane. The kidney maintains sodium levels in between, here we go, note this one, 135 through 145 milliequivalents. Sodium and potassium are regulated by aldosterone, which is a mineralocorticoid that's secreted by the adrenal cortex. The RAS system, which is renin-angiotensin aldosterone, is part of this is part of the system, which is where aldosterone comes from. Aldosterone secretion is influenced by circulating blood volume and concentrations of sodium and potassium. So if I look back at the urinary system, basically, so here, urinary system. Oh, actually, I'm going to be doing loop of Henle. So basically what's happening here, so if you follow my cursor, right in here, we're going to have from our afferent arteriole go to the glomerulus, and we're going to start filtering that blood out to make eventually urine. But so here, the cells in this glomerulus, we have macula densa cells, and they're going to be tasting the sodium and potassium levels. If they notice that there's low levels, they're going to talk to the juxtaglomerular cells, which are in here. You guys don't need to know these terms, but just to get a bigger picture view, juxtaglomerular cells are then going to secrete renin. Renin is going to go off, and it is going to change. Renin is going to go off and change angiotensinogen to angiotensin 1, an ACE converting enzyme, which is normally in the lungs, is going to change angiotensin 1 to angiotensin 2. Angiotensin 2 is going to stimulate aldosterone secretion, stimulate thirst, and cause vasoconstriction. Aldosterone is going to increase the reabsorption of sodium, which happens on the distal. They have it really weirdly set up here, but it's the distal tubule right here. And yeah. Wow. Normally it's right here, the distal tubule. So we're going to re-get that sodium in there so we collect up more. We can absorb more salt, and so water will follow. So we can increase that blood pressure. So basically, the whole RAS system, renin, angiotensin, aldosterone system, its purpose is to increase blood pressure. Now, switching over to when so I went over that. So switching over when we have too high of blood pressure and we want to decrease our blood pressure, natriuretic peptides come in. They're secreted from the atrium of the heart and brain. So we have those natriuretic peptides coming from the heart and the brain. And these peptides are natural antagonists of the RAS system. So they're opposite of what the renin, angiotensin, aldosterone system does. So renin and angiotensin, the RAS system wants to increase blood pressure. Natriuretic peptides wants to decrease blood pressure, and they do this so by vasodilating, which increases sodium and water excretion, thus decreasing blood pressure. So if we look back at this, so the RAS, the aldosterone, will keep us right into holding on to sodium. So we, when we get to the blood here, holding on to sodium, so the water will follow and we can increase the blood in here. Natriuretic peptides, they don't want that. So they keep the sodium in the tube so it can eventually be excreted by the bladder. So the RAS does not want salt to stay. The natriuretic peptides do not want salt to stay. The RAS system does want salt to stay. natriuretic peptides want decrease in blood pressure. The RAS want increase in blood pressure. Yep. Moving on. Okay. Sodium and chloride balance. So again, we're talking about the renin, angiotensin, aldosterone. Aldosterone promotes reabsorption of sodium and excretion of potassium. Oh, excretion of potassium to increase blood volume. Natriuretic peptides produced by the myocardium is released when there's an increase in pressure, and so its job is to decrease pressure by causing vasodilation to further excrete the sodium in H2O, which in result can help lower the blood pressure. Does that make sense? This one's a really hard topic to explain. I know I tripped up a few times in there, but I tried my best. Okay, now we have, we got a lot of slides. Gosh, okay. So the water balance, is regulated by ADH. ADH is secreted when plasma osmolality increases or circulating blood volume decreases. So, hey guys, back again. My storage ran out, so I need to move some of that other footage to my USB. Okay, so now we're talking about water balance, and it's regulated by ADH. ADH is secreted when plasma osmolality increases. So we have more solutes in the capillaries, and for some reason we don't have enough water in the capillaries within that. Or circulating blood volume decreases. So again, like not enough water, and we have increased plasma osmolality. Water deficits or sodium excess occurs with increased plasma osmolality. This stimulates hypothalamic osmoreceptors that trigger thirst within the pituitary gland to release ADH. The pituitary gland releases ADH and increases water absorption into the plasma and from the distal tubules and collecting ducts within the kidneys. So we're basically in the whole urinary system of the kidneys, we're going to reabsorb a lot of that water again because our blood pressure is decreasing. So this causes us to make more concentrated urine because rather than having like watery urine, we're just getting rid of that urea and ammonium and all of that because we pulled most of the water out of it. When osmolality is increased or blood flow is low, it triggers thirst and the release of ADH. Thirst makes us increase, take in more fluid, and increase ADH means we hold on to more of that water we take in. As water builds, retention develops, blood volume is increased, and osmolality goes down. ADH and thirst then decrease the more water we get in. So once our body's happy, that ADH is going to decrease and thirst is going to decrease because we can figure out that we're hydrated now. Excessive sweating and vasodilation can decrease blood volume and blood pressure, which can lead to situations like dehydration and fluid loss. Baroreceptors and nerve endings are sensitive to this change that stimulate the release of ADH from the pituitary gland to stimulate thirst. The volume receptors in the right and left atria of the heart vessels are are where these osmoreceptors are located. ADH secretion also occurs when atrial pressure drops. Reabsorption of water mediated by ADH then promotes the restoration of plasma volume and blood pressure. So again, ADH is kind of doing something like aldosterone's doing. So aldosterone's point was to hold on to sodium so we can increase water absorption. ADH is more like dealing with just water. It's wanting to reabsorb that water to increase blood pressure. So if we're testing, if the osmoreceptors test, oh wow, it's really concentrated, we need more water, it'll secrete ADH. And also if it's like, wow, the blood volume is really low, we need more water, it'll secrete ADH as well. Water and sodium balances are closely related. Water balances may fluctuate with the levels of sodium in the body and vice versa. These changes can relate to the tonicity of cells. Changes in tonicity in cells in relation to total body water are classified as isotonic, hypotonic, and hypertonic. I drew this out for you guys pretty well when we were going over net filtration. Isotonic is when it's equal with each other, so so the amount of water going in and out is equal. You could have isotonic fluid excess, which would lead to hypovolemia. And this can be caused by excess IV fluid, hypersecretion of aldosterone, hypersecretion of ADH, or effects of drugs that cause water retention. It can cause, the signs and symptoms cause weight gain, decreased HCT, and plasma protein concentrations, and neck veins may become distended, blood pressure increases, capillary hydrostatic pressure increases, which can lead to edema, pulmonary edema, and heart failure will then ensue. You can also have isotonic fluid loss, which leads to hypovolemia. So excess is hypervolemia. Um, Loss is hypovolemia. This can cause to excessive bleed out, extreme drainage, extreme sweating, inadequate fluid intake. This would be the signs and symptoms of this manifestations: rapid heart rate, flattened neck veins, decreased to normal blood pressure, prolonged dehydration or hypovolemic shock could lead to hypovolemic shock. Also, I want to note that dehydration and hypovolemia are different. I don't know why I just use the word dehydration, because they're different. So hypovolemia is when you don't have a lot of water, where dehydration is the loss of water. So I'll further explain that in the next slide. So here we go. Okay, so here we're going to talk about the difference between dehydration and hypovolemia. Dehydration can cause hypovolemia, but they're not the same thing. Okay, so elevated osmolality within the extracellular fluid in hypertonic fluid alterations, increased concentrations of sodium, or a deficit of extracellular fluid itself can cause hypertonic alterations. ECF has a hypertonic alteration. Water is attracted from the ICF to try to create a homeostatic state. This causes ICF dehydration. So Let me draw this out for you. So I'm going to put a line down the middle. Okay. So here we have a cell, and here we have a cell. So dehydration is when we have so many solutes out here and not enough water is out here to kind of equal out the solutes to cause an isotonic state. So this water is going to rush out. That would be dehydration. Now, hypovolemia is when it's equal, but we just have low water. So low H2O everywhere. So not enough. Low H2O everywhere, low volume of blood. We don't have a lot of quantity wise. This is where we don't have much water, so we're pulling from sources we shouldn't be pulling from. This is just quantity wise not enough. The quantity is okay, but it's getting lower in the water status that we're pulling from places we shouldn't be pulling from. Kind of makes sense. This is quantity of everything, low blood, low everything. This is just water related. So when I wrote low H2O, I mean low blood count too. So low BC. It's a little rough, but you get it. So causes the cells to shrink. Dehydration refers to loss of water, may also reflect to sodium loss. Pure water deficits are rare because usually people have the ability to access water. We lose a lot of water breathing, urinating, and sweating through our skin. Recognize this type of deficit or volume issue impacts many signs and symptoms. Low blood volume, and dehydration refers to water loss, tachycardia, fast heart rate, and weak pulses, and postural hypotension. It can include thirst, dry skin, and dry mucous membranes. So let me go over this again. So, sorry. I'm so sorry. So, this is dehydration is low H2O. Sorry, I put this on the wrong side. This is low H2O. This is low everything. I'm just going to put EV for everything. So low blood count, more than just low water. Okay, hypotonic alterations, osmolality of, I got something in my eyes. Okay, hypotonic alterations occur when osmolality of the ECF is less than normal. So I went over this earlier. It can cause overhydration because we have more solutes in our cell than outside the cell, and so water follows solutes. I drew this earlier. If you want to rewind back, you can. So now the water moves into the cell. It can this can lead to decrease in plasma volume, and a sign and symptom of this is hypovolemia. With water excess, it increases both ICF and ECF, so it can, with excess water, it can cause hypervolemia and water intoxication. Water excess is achieved through normal physiologic methods because is difficult to achieve because the kidneys are always regulating water balance. However, if you compulsively take in water, it can cause hypotonic fluid alterations. Acute renal failure can be at risk for water excess because our kidneys aren't working too well in acute renal failure. Also, if ADH is not being regulated, if we're secreting too much ADH, we're going to be holding on to way too much water, and that can lead to water excess. It can lead to cerebral edema, confusions, convulsions, weakness, weight gain. And we all know about the Sacramento Wii game, and the girl died because she excessively drank way too much water without peeing. Sodium. Now we're talking about electrolyte concentrations. So normal serum sodium concentration is 135 to 145 milliequivalents. And retaining sodium would cause high blood pressure because our water follows salt, and so we would hold on to more water, and it would increase our blood pressure. So eating a lot of sodium would have the same effects as like secreting aldosterone. Is a major electrolyte in the blood. It provides osmotic pressure in the blood to cause water to move into the blood. As you increase the sodium, you will also increase blood volume and blood pressure. Hypernatremia is when the serum sodium levels exceed 145 milliequivalents, which could be caused by retention or infusion of sodium, decreased intake, or increased water loss. Yeah. So sodium is largely in extracellular fluid, so it increases sodium concentration. This causes intracellular dehydration. So when we're talking about serum, we're talking about outside of the cell. So all of these are the serum levels, and serum sits outside of the cells. Keep that in mind. We're not talking about inside the cells. We're talking about extracellular, outside of the cells. So if we have increased sodium outside of the cells, drawing it again, so many dots. So we're talking about serum levels, so we're talking outside of the cell. Hyper, so more solutes outside of the cell. The water is going to follow these solutes and cause dehydration. Yeah. And this can be caused by oversecretion of aldosterone or oversecretion of adrenocorticotropic hormone. So thinking back on the endocrine system, we release ACTH, which is adrenocorticotropin hormone. ACTH stimulates the secretion of aldosterone. So basically, oversecretion of ACTH would be a secondary endocrine problem, and then the oversecretion of aldosterone would be a tertiary problem. So moving on. Hyponatremia is when we have low levels of salt, below 135. So below 135 milliequivalents outside of the cell, and this would cause a hypotonic solution. And this could cause cellular swelling because we don't have enough solutes outside of the cell. So the water is going to follow the solutes inside of the cell, causing cellular swelling. This can be caused to burns, suctioning of GI, the use of diuretics, and low diets in sodium. Low sodium levels can depolarize. Low sodium levels negatively impact the cell's ability to depolarize and repolarize normally, which leads to neuro problems. So, like I showed earlier, the action potential. You saw like how sodium goes in and potassium goes out. If we don't have enough sodium to reach us to threshold, how are we going to depolarize and cause an action potential? Exactly, we can't because we don't have that sodium making us able to. It can hypovolemia. ECF loss can cause hypovolemia, hypotension, tachycardia, decreased urine. Yeah. Major potassium is a major intracellular cation. And different amounts of potassium are needed in the intracellular fluid and extracellular fluids, regulated by the sodium-potassium pump. Potassium influence the regulation of ICF osmolality and fluid balance, regulation of intracellular electrical neutrality in relation to hydrogen and sodium. So it helps regulate those two other ions as well. Potassium is essential for the transmission and conduction of nerve impulses. So back again to that action potential picture I showed. Normal cardiac rhythms, and skeletal and smooth muscle contraction. With potassium, you want to think heart. Potassium is usually within the extracellular fluid and is 3.5 to 5 milliequivalents per liter. So changes in pH can affect potassium balance. Hey, Mom, can you talk quieter? Sorry. They're laughing at me. When body is in acidic state, hydrogen ions accumulate in the intracellular and potassium shifts out to maintain the balance of cations across the membrane. Hypokalemia occurs. Hypokalemia occurs when serum potassium levels, so outside of the cell, serum, anytime you see serum, know it's outside of the cell, levels fall below 3.5 and indicate total body loss of potassium. When potassium is lost, concentrating gradient favors potassium from the cell to the extracellular fluid, which lowers the total body potassium levels. The causes of this could be decreased calcium and potassium intake, increase entry of potassium in cells. So the potassium is moving inside the cells rather than sitting in the serum levels outside of the cells. Increased loss of body potassium due to GI and renal disorders or laxative abuse. Hypokalemia is rare but could occur within the malnourished. Signs and symptoms. Losses are usually asymptomatic if it's mild, but severe loss can cause neuromuscular and cardiac, um, such as neuromuscular weakness, atony of muscle, and cardiac dysrhythmias. So focus on this. It's below 3.5. Um, Also, with this, you would have a shallow T wave and prominent U wave and depression in the ST. So depression, so think of STD in this, STD, ST depression, and shallow T wave and prominent U wave. Okay. Hyperkalemia. So more potassium outside of the cell rather than inside is above 5.5. As long as kidneys are functioning appropriately, hyperkalemia is rare. It can be caused by increased cellular uptake and renal excretion. Oh, it can. Okay, wait. It can be corrected by increased cellular uptake and renal excretion. The causes are increased intake, shift from potassium from in the cells to outside, decreased kidney functioning, drugs that decrease kidney function, trauma, insulin deficiencies, burns can also lead to hyperkalemic steaks, I'm hungry, states. Signs and symptoms can cause mild attacks involved in increased neuromuscular ability. Severe attacks would be muscle weakness, loss of tone, paralysis, decreased cardiac conduction, and would show a depressed ST segment, prolonged PR intervals, widened QRS complex. So this is above 5.5. Still confused on why though. The ST segment would be depressed just like hypokalemia, but weird. Keep that in mind. Hypocalcemia. So, oh, I skipped a slide. Calcium is mostly located within the bone. It's necessary for the structures of bones, cellular receptor function, blood clotting, membrane stability, nerve impulses, muscle contraction. Its concentrations in the serum is normally 8.8 to 10.5. Hypo could be inadequate intestine absorption, deposition of ionized calcium into the bone or soft tissue, decreased PTH. So PTH is what takes calcium from the bone to make higher calcium blood levels. So if we have a decrease in that, we're not getting enough calcium. And decrease in vitamin D. Nutritional deficiencies can cause this. So inadequate dairy products or leafy green vegetables. Effects can cause neuromuscular excitability, so spasms, tingling, twitching, cramps, hyperactive bowel sounds. You can get convulsions and tetany if the case gets serious, and prolonged QT interval. Hypercalcemia, so increased calcium, so hyperparathyroidism, bone metastases due to breast, prostate, renal, and cervical cancer, sarcoidosis, excess vitamin D to many tumors that help overproduce PTH. The effects can cause fatigue, weakness, anorexia, nausea, constipation, impaired functioning, kidney stones, dysrhythmia, um, bradycardia, cardiac arrest, bone pain, osteoporosis. Um, so, yeah, your bones become weak because you're pulling so much calcium from the bones, and so it can go into the blood. That you're going to become weak and fragile at that point. Um, that's also called. You'll see that in osteoporosis, increased PTH in there. It mostly happens in women, but yeah, they have weaker bones because they're releasing PTH like no other and pulling that calcium from the bones. Okay, moving on. Okay, let's talk about learning objectives. So intracellular fluid. Let me go to the question. There we go. Intracellular fluid, 2/3 compartments of total body water. Extracellular fluid, 1/3. It's divided between the plasma and space outside of the cells in the interstitial fluid. Capillary hydrostatic pressure, the pushing out of the capillary. Plasma oncotic, the pulling into the capillary. Interstitial hydrostatic, pushing out of the tissue. Interstitial oncotic, pulling back into the tissue. And just note that capillary has bigger effects than interstitial most of the time. Net filtration equation is forces favoring filtration, subtracting the forces opposing filtration. So filtration minus reabsorption. Filtration is capillary hydrostatic and interstitial oncotic. Reabsorption forces are capillary oncotic and interstitial hydrostatic. Okay. Edema is describe the causation and pathophysiological process of edema. So edema is excess accumulation of fluid within the tissues. It's often not a problem of fluid excess, just a problem in fluid distribution. It could be caused by increase of forces favoring fluid filtration. So the pushing into the interstitials, or decrease pulling back into the capillary, or lymph obstruction, or increased capillary permeability. So if we get like a hole from a burn in our capillaries and now stuff is just spilling into our tissues. Localized edema is within a site of injury. Generalized edema is all over the body, and dependent edema is gravity dependent, so pulling into the feet. You get that when you're pregnant. Discuss the regulatory processes of sodium and water balance in the body with antidiuretic, RAS, and antinatriuretic. Antidiuretic is holding on to water, helping you become more hydrated to increase blood pressure. RAS is renin, angiotensin, aldosterone. We went over that. So renin converts angiotensinogen to angiotensin 1, ACE to angiotensin 2, that was my dad, and then angiotensin 2 helps secrete aldosterone. Aldosterone holds on to sodium, so that sodium can be used to attract water forces, to hold on to water, to all increase blood pressure. Now, opposing the ADH and RAS, we have atrial natriuretic hormones, and these guys, these guys, their job is to decrease high blood pressure levels. So they will detect high blood pressure and they will cause vasodilation to get rid of more of that sodium and water, which would cause lowering of the blood pressure. Um, Hypotonic, isotonic, and hypertonic. I drew pictures of this and talked about it so much. So just really go over those again. Know the clinical manifestations of hyper and hypos of all the electrolytes. So I'm just going to say the ranges. So in sodium, so natremia is 135 to 145. Potassium is 3.5 to 5.5. Choline is but 8.5 to 10. And continuing on. And that's pretty much all we need to know. So the causes of water deficit. So dehydration is loss of sodium and water, which is rare. It can cause in pure water deficits. It can cause comatose or paralyzation. Losses of water through skin, lowered urine formation, are prime signs of dehydration. Manifestations are headache, thirst, dry skin, dry mucous membranes, elevated temperature, weight loss, decreased urine output, and confusion. Hypovolemia would cause signs of that would be tachycardia, weak pulse, postural hypotension. Water intoxication is impossible if kidneys are working functionally. So this is number 9 now, manifestations of water excess. So it's rare unless your kidneys are really jacked up or you're being crazy and compulsively drinking water. So you in this, you either have renal failure, congestive heart failure, cirrhosis, oversecretion of ADH, which is SIADH, decreased urine formation. Manifestations of this are edema, confusion, convulsions, weakness, nausea, muscle twitching, weight gain, headache. So yeah. 10 is signs of SIADH. This is also known as vasopressin deregulation, and it enhances water retention. And if you have too much of this, this is called inappropriate. And usually the signs are ADH levels are elevated. You get hyponatremia because too much water is diluting too much of that sodium. Yeah, and you start getting cerebral edema, confusion, convulsions, weakness, nausea, twitching, weight gain, all of that. Basically the same signs as you would as water excess, because you're reabsorbing so much water. The treatment for this is to give small amounts of IV with a hypertonic sodium chloride. 11, the distribution, function, and regulation of potassium. This so with potassium, extracellular should be 5 milliequivalents usually, and intracellular is 156. I don't think we really need to know that too in depth on intracellular, but know the plasma. extracellular ranges. It is regulated, potassium is regulated by ICF osmolality, resting membrane potential, glycogen in liver, skeletal muscles. It's potassium is a huge intracellular ion and is regulated by kidneys through aldosterone and insulin secretion, and also changes if our body pH changes. Potassium adaptation allows body to accommodate and gradually increase levels of potassium intake. Identify the basic causes and clinical manifestations of hyperkalemia and hypokalemia. I went over that earlier, but that's over 5.5 milliequivalents. It could be caused by decreased renal excretion, shift from ICF to ECF, or increased potassium intake. So we have a lot of potassium in our intracellular fluid, 156 guys. If that shifts just a little bit to the extracellular fluid, we're going overboard, and that can cause problems. The causes could be renal. Okay, so sorry it cut me off again. But if there's a shift from ICF to ECF, we'll get hyperkalemia. That's just not good because we have so much in our intercellular fluid and not a lot in our extracellular. So if we shift just a little bit of that, like, man, you're going to have problems. It can be caused by renal excretion problems, excessive potassium intake, excess cell membrane permeability, hypoxia, acidosis, insulin deficiencies, decreased renal secretion. The treatment would be correcting potassium excess by administering calcium, glutamate, glucose, insulin, oral, rectal administration of the cations, exchange, resins, dialysis could help. Hypokalemia is below 3.5 and is reduced intake. Too much from the ECF is going into the ICF, and were loss of potassium from body stores. This could be caused by increased aldosterone secretion or increased renal secretion. Treatment, eat foods rich in potassium or an IV replacement. The roles of hydrogen ion is basically to maintain pH. The lungs, kidneys, bones are major regulation organs for acid-base balance. So it can body acids exist in either volatile, so respiratory acids eliminated as CO2, or non-volatile by being eliminated by the kidneys. Yep. And hydrogen ions also depict the speed of enzymatic reactions on top of dealing with pH. Plasma buffers. So how they help with pH is they can consume excess hydrogen ions or hydroxyl ions, so base ions, and with the consumption of extra ions, the pH doesn't, with a consumption of extra ions, the pH does not fluctuate. Two important, so say if you eat something really acidic, these buffers, what it's trying to say is that these buffers will help so your pH doesn't go into whack just because you ate something acidic. The two important plasma buffer systems are the carbonic acid bicarbonate shift and the protein hemoglobin. And also phosphate. We'll throw that one in there. They can transport extra ions to respiratory and renal systems for excretion by exhalation or urine through the urine. Explain how kidneys and lungs regulate acid balance. So the respiratory system can excrete carbon dioxide through exhalation, which would bring the pH back down. So just keep in mind, if you have an increase in CO2, you're going to have an increase in hydrogen and a decrease in pH. If you have a decrease in hydrogen ions, a decrease in CO2, you're going to have an increase in pH. Okay? Um, Moving on, the renal system, bicarbonate can be reabsorbed or regulated by the kidneys and can excrete extra hydrogen ions through the urine. Bicarbonate, like if we are in an acidic state, we would want more bicarbonate to help suck up those hydrogen ions, and the renal system can depict, do we need more bicarbonate or not? Are we acidic? If we are acidic, we'll keep that extra bicarbonate. If we're in alkalosis, we'll need to get rid of that because we want to hold on to more hydrogen ions so we can bring that acidic state, or we can bring that not acidic state, alkaline state, and increase those hydrogens so we can become back to homeostasis. So let me say that again. We'd have more bicarbonate in acidic states and less bicarbonate in alkaline states. And in the respiratory system, we'd breathe off. So we'd breathe more in acidic states and we'll breathe less in alkaline states. Differentiate between respiratory and metabolic disorders. So respiratory acidosis can be caused by hypoventilation, so holding on to too much carbon dioxide, which would end up causing us to be in an acidic state, lowering the pH, increasing the hydrogen ions. Respiratory alkalosis occurs through hyperventilation. So we're breathing off too much carbon dioxide and we don't have enough hydrogen ions in our bodies. So so we're going to have an increase in pH because we don't have enough hydrogen ions. We blew them all off through respiratory. Metabolic acidosis is when we have we have a bicarbonate loss or increase in non-carbonic acid, so increase hydrogens or decrease in bicarbonate, and yeah, so metabolic alkalosis is when we have a loss in hydrogen ions or acids and too much bicarbonate. Okay, yeah, so now just go on to your guys' practice book and review some of that. I'll review some of this right now. Thirst is prompted by osmoreceptors because it's detecting osmolality. Intracellular fluid is the same as extracellular fluid. So water can cross freely through aquaporins. Albumin is responsible for oncotic pressure. Isotonic fluid excess causes hypervolemia. Fluid accumulation in the stomach region would be ascites. Increased carbon dioxide would be hypercapnia. Sodium is greater in extracellular fluid. Potassium is greater in intracellular fluid. The pH of an acidic, the pH is greater in a alkaline solution. Alkaline, so pH goes up in alkaline solutions, pH goes down in acidic solutions. Sorry, I was reading off the practice book and it was asking which is greater, and so I was like reading it and I was like, oh, probably shouldn't say that. You would have a greater percent of body water in a lean woman because the more fat you have, the more dehydrated you are. Infants have greater body water. Yeah, that's pretty much it, y'all. Okay, so moving on to chapter 6. Also, guys, practice your ABG tic-tac-toes as well. Huge thing.